Good afternoon, excuse me. Good morning here in the States. Good afternoon in England and Spain and in Europe. Thank you so much, Maria and Gurjeet, for this great honor to share with you today in some teaching and learning about such an important topic, herpes zoster ophthalmicus, a topic that is something that not only cornea experts take care of and see on a regular basis, but every ophthalmologist sees patients with shingles, with herpes zoster, and it's crucial to understand the diagnosis, proper management strategies, and prevention with the vaccines. Maria, as people start, can you please continue to admit people, because I see that screen popping up periodically, and I'm going to go right ahead with my talk. So my talk is, and by the way, as Maria said, I'll be talking for about 45 minutes. Gurjeet will be talking for about 20 minutes, and then we're going to have 20 minutes or so of discussion about some essential topics that we feel it's important to discuss and to comment on. Okay, so here we go. So my talk is Herpes Zoster Ophthalmicus 2020, Diagnosis, Management, and Prevention. I have no financial interest in anything I'll be discussing this afternoon. So I thought we would start with a case presentation. And that is this case here, this patient that I saw a number of years ago, a 71-year-old white female with a 2-day history of a right forehead rash and discomfort, best corrected vision 20/25 in both eyes. We diagnosed the cutaneous eruption of herpes zoster, so herpes zoster ophthalmicus, and standard of care is to use, when you can use valacyclovir or famciclovir, we recommend it, as I'll talk about, 1,000 milligrams 3 times a day for 7 days. 1 week later, the lesions were crusted. She was pain-free. Again, no ocular involvement, meaning no keratitis, no conjunctivitis, no change in vision. 2 weeks later, she came back as an unscheduled visit with right eye irritation, and she had these temporal corneal lesions, these sort of pleomorphic lesions that stained poorly, but stained with fluorescein and a bit with rose bengal as well. I didn't have lissamine that day. And this patient was diagnosed as having a herpes zoster epithelial keratitis. And because, and we'll discuss whether this is an infectious or not manifestation of HZO, she was just treated with topical ocular lubricants. 4 weeks later, she came back with decreased vision 20/80, diagnosed a herpes zoster ophthalmicus keratouveitis and endotheliitis. You see the mutton fat, large and small keratic precipitates on the endothelium. There was corneal edema with an intact epithelium. Intraocular pressure was 38 millimeters, and 2+ cell and flare with the KP, as I mentioned. She was started on 1% prednisolone acetate every 2 hours and a combination dorzolamide timolol product twice a day, and homatropine for cycloplegia, BID. She was tapered on those medications, and then she came back 3 months later with visual acuity 2400 with what we see here, which is a neurotrophic keratopathy. I prefer the term neurotrophic keratopathy to neurotrophic keratitis, stromal haze, and a progressive cataract. The steroids were rapidly tapered, topical steroids were rapidly tapered. She was placed on a bandage contact lens for a couple of days, no improvement. And so then we took her to the operating room. She refused tarsorrhaphy. We took her to the operating room for a conjunctival flap. And I just want to mention, with a momentary digression, the meticulous attention that one needs to pay when you do conjunctival flaps. In my opinion, these are the hardest operations to do, or among the hardest operations for a corneal specialist to do, specifically because to remove the Tenon's fascia from the underlying Tenon's fascia from conjunctiva without buttonholing is an extremely difficult procedure to do properly, especially if you have to do a complete Gunderson flap where you need a lot of conjunctival tissue and not just a bridge flap, which of course are much easier to do. And of course, no tension. If you notice, it's quite vascularized at the beginning, but after 6 months, the flap thinned out beautifully. You can see that white cataract. She's now hand motion, trace cell and flare, normal intraocular pressure, 18. So the question was then, do we even try to take the cataract out of this patient? So I talked to her, and we decided to go forward with cataract surgery. The inflammation was controlled preoperatively. The conjunctival flap was left in situ, thin and intact as it is. Phacoemulsification was performed with a scleral incision at 10 o'clock to avoid the long posterior nerves, which are largely at 9 and 3 o'clock. And so I'm still seeing some of the folks coming in a bit late. So we did that. No limbal relaxing incisions in this case, put a monofocal intraocular lens in, and she improved from hand motion to 20/50 through that conjunctival flap. Slow taper on the prednisolone, and we had her on lodiprednol, 0.5% once a day, monitoring her intraocular pressure and AC. So that procedure in this case is a universe of decision-making, diagnostic making, and management strategies in the context of herpes zoster ophthalmicus. And if you notice here, the salient points are to control the inflammation, the way we use preoperative and postoperative steroids, the way we tapered quickly the topical steroids when we saw the patient had a neurotrophic lesion, the fact that we used a scleral incision in this particular case for healing reasons, and that we avoided the horizontal meridian because we already know that in zoster, there's a diminution in corneal sensation. There is at least a hyposthesia meaning diminished corneal sensation. And sometimes there can be a profound anesthesia, meaning absence of corneal sensation. So we want to avoid the larger plexus, the larger neural plexi, which are at 3 and 9 o'clock. And be aware that these patients are very tricky to manage postoperatively. There can be both or either an intraocular pressure rise postoperatively, and of course, Gurjeet would discuss the issue of IOP rise in general in setting of herpes zoster. And there can also be paradoxically hypotony. If there's profound inflammation and damage to the ciliary processes, there can actually be a hypotony. Herpes zoster derives from the Greek term herpein, which means to spread or creep, and zoster, which is a girdle or a sword or a belt or a zone because of the way it manifests in the thoracic and lumbar dermatomes, which is usually as a belt-like rash. The word shingles comes, interestingly, from the Latin cingulus, which means belt. So again, that concept or that notion of the belt-like distribution of the rash. And of course, if the first division of the trigeminal is involved, that term becomes herpes zoster ophthalmicus. Here's a nice little slide from Merck, which shows us where the herpes zoster virus lies in the context of the human herpes virus family. It's an alpha herpes, it's an alpha human herpes virus, an alpha HHV, very similar to, but not identical with, very similar to its cousin, if you will, herpes simplex virus karyotype, herpes simplex virus, HSV. So the varicella zoster virus, VZV, which is what becomes the zoster rash on the recurrence or recrudescence, is a close relative in the alpha human herpes virus family, as distinguished from Epstein-Barr virus, CMV virus, HHV-8, and other types of viruses. Those are the gamma HHV group, and it's in contradistinction to the beta HHV group as well. As I said, VZV causes the primary infection of varicella, which we call chickenpox in the vernacular, and reactivation is herpes zoster, which we would call shingles in the vernacular. Remember that this is a DNA virus. It has a phospholipoprotein envelope that is elaborated by host cell membrane. And there is this very important viral glycoprotein on the surface, which is the viral glycoprotein E. And that's going to become important when we discuss Shingrix at the end of the hour, which is the current vaccine that's preferred here in the States to try to prevent this condition from occurring in our patients. There's only one serotype of varicella zoster virus, which is the chickenpox virus. We humans are the only reservoir. It's a highly contagious virus. Interestingly, before the Varivax vaccine, remember there's Varivax, Zostavax, and Shingrix, which we'll be discussing. Before the Varivax vaccine, the chickenpox vaccine, became available by Merck in 1996, over 95% of the population here over the age of 20 had been exposed to chickenpox. if you remember nothing else from my talk, please remember cell-mediated immunity, CMI, because cell-mediated immunity is the essential immunological underpinning of the problem. It's the cell-mediated immunity, specifically a type of CD4 T cell, that really does the bulk of the work to clear virally infected cells and to limit viral replication. Decreased CMI increases the risk of herpes zoster anywhere in the body. And because it decreased CMI increases the risk of zoster, it therefore consequentially increases the risk of post-herpetic neuralgia, which we will abbreviate PHN. I will not be discussing PHN today. That's a neurological problem, and for the interest of focus and time to front of the eye matters, we will elide PHN diagnosis and management strategies for this talk. We can go through it on a different talk perhaps in the future. So vis-a-vis herpes zoster and varicella. After the varicella zoster virus occurs, it often can become latent in the trigeminal, well, in the case of herpes zoster, in the trigeminal ganglion. In the case of herpes zoster elsewhere, in the ganglia that are related to the cutaneous distribution of that particular occurrence. And recurrence can occur as a result of many things: trauma, fever, stress, oral corticosteroids, UV light, sunlight, wind, interestingly, even menstruation. Both HSV and VZV have been shown to recur as a consequence of the changes in hormonal situation during menstruation. So that's a fascinating side point, and as a consequence of surgery. Today, and I've had to change this talk, I've given this talk over 25 years at the American Academy of Ophthalmology with my good friend Doyle Stulting of Emory University in Atlanta. When we first gave this talk back in 1984, the numbers were 1 million here and 100,000 here. And today in the United States, we have fewer than 100,000 new cases of varicella a year in the United States, and we have over 1.3 million new cases of herpes zoster. The age ranges, of course, for varicella are usually in the young folks, and in zoster, it's usually, although not always, in people that are over, really that should be about 55 and over. The issue of seasonal variation, it peaks in the spring with varicella. There's no seasonal variation in zoster. And transmission of varicella, it's very highly communicable and airborne by a respiratory system. And in zoster, it's usually after exposure or, of course, recrudescence after a prior attack as a child, usually, with varicella zoster. So the lifetime risk of zoster is 1 in 3, meaning 1 in 3 people here in the States will have shingles in their life. Over 85%, I'm sorry, and the risk is 1 in 2, 50% of people over the age of 85. So 1 in 2 people over the age of 85, will have zoster in their life. It's a very common problem in dermatology practices. About 5% of encounters are related to shingles. And interestingly, the numbers are a little variable, but about 10% of cases of zoster are herpes zoster ophthalmicus. So one of the board questions, one of the American Board of Ophthalmology questions is as follows. Where's the most common location of herpes zoster? The answer is the thoracic dermatomes in aggregate. What is the most common single dermatomal involvement in zoster? And this is crucial. The answer is V1, or the trigeminal nerve, V1, V2, or V3. And in V1, it's zoster. So the most common single dermatomal involvement in zoster is the first division of the trigeminal nerve. We talked about the recurrences with age, immunosuppression, trauma, radiation, infections even, and stress. And these are all related to decreased cell-mediated immunity. Do note here, lymphoproliferative malignancies, we'll discuss a bit later in the talk, the issue of the relationship between zoster and cancer. That's a crucial discussion, a complex discussion, but an important one. Viral replication from the cytopathological effect with inflammation, ischemic vasculitis, and scarring. We can see here the dramatic damage to the iris stroma with aggregations of lymphocytes and macrophages here. It causes an ischemic vasculitis, which is why you can see scar tissue more commonly in facial zoster because of the fact that it is an ischemic vasculitis and it causes necrosis deep into the dermis. This is a case I presented as part of a chapter that I had written for Duane's ophthalmology text back in 1996, which was a patient who presented with what looked like temporal arteritis, and herpes zoster can certainly clinically mimic TA, temporal arteritis. The difference between the two ultrastructurally is that there's no damage to the tunica intima in the vessels here, but there's certainly perivascular cuffing with lymphocytes and even a couple of macrophages here. So that's an important point to make in terms of a phenomenological issue. So here's a patient who I saw my very first week in practice. It was a weekend, it was a Friday night, and she came in with malaise, a history of malaise and low-grade fever and a headache. You can see some swelling here, but I didn't pick it up that afternoon. I just took a picture. I had my trusty Nikon macro lens. I took thousands of photographs in my career to document the fascinating external disease problems that we all face as front of eye specialists. She had some sensory abnormalities, a little bit of hypesthesia, and a lot of pain. And the pain was out of proportion to what I saw. She had hyperesthesia, meaning sensitivity when we touched, allodynia, which is an altered sensation of pain, a burning, itching type of pain. I admitted her that night to do a temporal artery biopsy on Saturday morning. And the next morning when I came in to see her preoperatively in the hospital, this is what she looked like. She was moribund with a lot of hemorrhage on this side. Notice that there is contiguous edema on the other side. And that's because in this case, that doesn't necessarily mean dissemination. It means that the pain was so severe on her right side that she slept on her left side, and therefore there would be dependent edema from gravity. Notice also the eruption on the side of the tip of the nose. The chronic phases of zoster are the most devastating one for us front of the eye people would be corneal involvement with neurotrophic keratopathy and postherpetic neuralgia. Those are very important problems that we have to understand and manage. The characteristic eruption is papules becoming vesicles on erythematous spaces, which crust in 7 to 10 days and can lead to scarring because of that deeper ischemic vasculitis in this condition. In patients who have an immunocompromised underpinning, zoster can be very atypical in its presentation. It can show up on both sides of the midline, and it's often taught that in immunocompetent patients, zoster will not cross over to the other side. Multiple dermatomes, usually skipping dermatomes, multiple dermatomes involved. And of course, you can have a viremia here, persistent viremia, which can cause a pulmonitis, hepatitis, meningitis. It's a devastating and lethal disease in the immunocompromised host. As I mentioned, the thoracic dermatomes in aggregate are the most common location, and the trigeminal nerve is the most frequent single dermatome involved, with the ophthalmic division being the most common branch of the trigeminal that is involved. So you remember from our neuroanatomy in medical school that the frontal branch of the ophthalmic division of 5 innervates the upper eyelid, forehead, and superior conjunctiva. The nasociliary branch innervates the sinuses, lids, alae nasae, which is the side of the tip of the nose, the wing of the nose, and the conjunctiva, cornea, iris, sclera, and choroid. This is crucial. This paragraph, this little box, is crucial to memorize. And the lacrimal branch innervates the lacrimal gland and the temporal upper lid. Looking at Grant's anatomy, we can follow the lacrimal nerve here and the frontal nerve here, and notice the supratrochlear division, the supraorbital division. You also can see here the ophthalmic artery. So that's a gross image of the top. We are all taught in medical school to look for Hutchinson's sign, but whether or not Hutchinson's sign exists, there is often a ocular involvement in herpes zoster ophthalmicus. If Hutchinson's sign, which is involvement of the ala nasae, ala in Latin means wing, like the wings of an airplane, nasae is the genitive singular of nasa or nasa, which is nose, wing of the nose, there's 50% chance of the eye being involved, which obviously means that even if Hutchinson's sign is not present, 50% of eyes, if not more, as Gurjeet will discuss, can have ocular involvement. But why would there be this relationship? And that's because the ophthalmic division of the trigeminal and the nasociliary nerve. So here is the anterior ethmoidal nerve, which innervates the nose. And here is the long ciliary nerves, which are branches of the nasociliary. So there's the nasociliary. It branches into long posterior, and the other main trunk goes forward to give the anterior ethmoidal. That's the neuroanatomical underpinning of Hutchinson's sign. You should also know about Ramsay-Hunt syndrome, which is another vernacular nosological term for seventh nerve involvement. You all think of the seventh nerve as a motor nerve, which it is. 95% of the nerve is motor, but there's a somatic afferent twig of 7, the nervus or nervus intermedius, the nervus intermedius, which is sensory. And if that gets involved with zoster, you can have not only motor palsy from the motor part of 7 being nailed by the zoster virus, but afferent lesions, meaning you could have vesicular lesions on the ear, as well as vertigo and balance problems from damage to the very, very close by 8th cranial nerve, the vestibular branch of the 8th nerve. The clinical signs of zoster are obvious. It's a cutaneous rash, thoracic here. We see it here with the crusting in the V1 area. And a little bit of V2 as well here, but mostly V1. And here again, a classic V1 involvement with alanase involvement. If you don't really know what you're dealing with, you could certainly do a prep of one of the vesicles, looking for multinucleated giant cells. You could certainly look for Cowdrey type A bodies, which are also called Lipschitz type 2 bodies, which are intranuclear inclusions. Other ways of diagnosing zoster, if you can't make the diagnosis on the clinical eruption, because there are cases that don't show that, you can look at direct immunofluorescence, PCR, and a test that I really like a lot, which is the ELVIS test, the enzyme-linked immunoassay, which in 24 hours gives you yes or no, meaning yes, this is a herpes virus infection, and if yes, it tells us HSV1, HSV2, or varicella zoster. So in 24 hours, you can actually get very powerful information. None of these tests are 100% sensitive and specific, as you might imagine, but notice that the ELVIS test, which is easily available now, gives a 90% sensitivity and specificity. Remember that zoster can mimic other conditions, or other conditions, can have a zosteriform look. So herpes simplex can manifest in a zosteriform rash. Impetigo certainly can sort of look like a V1 involvement, as can contact dermatitis. So remember these dermatological conditions that are mimickers of herpes zoster. Let's go through what can happen to zoster in the eye anatomically from front to back. I'm going to not discuss the retinal complications of zoster, because this is a front of eye discussion hour and a half, and also for the interest of time, I want to make sure that I bring us into the management strategies. So you can certainly have scarring of the lids, sloughing, batarosis, cicatricial ectropion or entropion. The conjunctivitis of zoster is not specific. It can be either papillary or follicular. You can sometimes have pseudomembranes, petechiae, and even vesicles. I've actually seen conjunctival vesicles in zoster. Tom Liesgang, a wonderful cornea specialist whom I have known over the decades, who was a chief resident at Bascom Palmer, where I did my residency. Tom was there right before I came on board, has written deeply and broadly on the corneal sequelae of zoster, and the fact that, as we discussed, about half the patients who have herpes zoster ophthalmicus, meaning whether they have Hutchinson's sign or not, at least half will have some ocular involvement, meaning corneal involvement. So the classification scheme that Dr. Liesgang has proposed is one of acute, delayed, and chronic manifestations. The acute manifestations are commonly the punctate epithelial keratitis, a dendriform keratitis, anterior stromal infiltrates, or a keratouveitis. This punctate epitheliopathy can occur, if it's going to occur, early on, meaning a few days after the onset of the skin rash, 5 to 10 days later. These lesions are pleomorphic, meaning they move around, evanescent, meaning they come and go. And whether they're infectious or not depends on when exactly you culture them. There were 2 famous articles in the Archives of Ophthalmology many, many years ago. in the 70s about whether these lesions are infectious or not, and it really depends on when you culture. Most of the time, I believe they're not infectious, and I don't treat these patients with topical antivirals because we don't have them that are FDA approved for HZ. I'd like to hear what you folks are doing over in Europe with topical acyclovir. You can certainly consider ganciclovir because ganciclovir in vitro certainly has activity against the VZV virus. So that could be a possible strategy there. So these lesions can sometimes then coalesce into a dendriform keratitis. And I like to distinguish the dendriform keratides from the herpes simplex virus dendrite. The Zoster dendriform keratitis is elevated, not depressed. It has no terminal end bulbs like the simplex virus does. It's stippled. It has poor staining with both rose bengal, fluorescein, and lissamine. Whereas the herpes simplex virus dendrite is ulcerated, meaning you're digging into the cornea. The Zoster dendriform lesions, the Zoster dendriform lesions are elevated plaque-like as if you're throwing latex paint on a wall. A very big difference when you look at them at the slit lamp. Sometimes these lesions can evolve into anterior stromal infiltrates with a ground glass appearance. These are immune responsive and steroid sensitive types of Zoster keratitis. Some of the delayed lesions are, this is a classic example of IK, interstitial keratitis. We don't see that much anymore because we don't see tuberculosis in the eye much anymore, or syphilis in the eye, but this is what IK looks like. It's a blood and thunder, if you will, cornea. You can also get mucus plaques, disciform edema, and peripheral ulcerative keratitis. The Zoster mucus plaques are, again, can be either an early or late manifestation of herpes zoster. They are elevated, wandering, evanescent, and represent desquamated abnormal epithelium. They are steroid insensitive. These should be treated with, take a photograph and treat them with non-preserved artificial tears. I mentioned disciform edema. This is not specific to zoster. This patient with disciform edema could have another type of viral lesion. This could certainly be HSV. In fact, I remember Klaus Dolman at Harvard giving this beautiful talk on herpes simplex, telling us that the most common reason for unilateral phakic corneal edema, the most common reason for unilateral phakic corneal edema is herpes simplex virus. Remember that. That's a crucial pearl from one of the great cornea specialists of our time. This is indistinguishable from the HSV edema. It's a non-infectious aspect of herpes zoster. It is steroid responsive. I would treat these patients with topical steroids and perhaps also cycloplegia, as we'll see. Some of the chronic sequelae are also things like exposure and bullous keratopathy, the neurotrophic keratopathy we saw in the patient that led the hour, and certainly the chronic epithelial keratitis in patients who have AIDS. Lipoidal scarring can occur sometimes, and if the lipoidal scarring is central and visually significant, and if the corneal sensation is intact, lots of ifs there. It's an if clause with several ifs. You can consider corneal transplantation. One of the few times that I would consider corneal transplantation in the setting of HZO. Neurotrophic keratopathy is one of the worst things you could possibly think of to manage. It's extremely difficult. These horizontal central lesions are absent epithelium. You can see the rolled edges. There's no way that epithelium is going to breach the gap here. It's trying with vessels to breach this gap. There's profound hyposthesia. If this is untreated, it can certainly lead to desmetocele formation and corneal perforation. The chronic infectious lesions of AIDS in zoster they resemble the acute dendriform zoster lesions. These lesions are infectious. They can occur months to years after the rash, and they are sensitive to topical antivirals. So here you could consider trifluridine or ganciclovir to treat these patients in the setting of AIDS who have these chronic infectious herpes zoster keratitis lesions. Episcleritis or scleritis can occur months or even years after the rash. So you have to always ask patients in whom you see a case of episcleritis or scleritis if they've ever had shingles of their face. And most people would remember if they did or not. Zoster keratouveitis, which Jutley will discuss in a few minutes, is an important aspect of the disease. It has a lot of inflammatory consequences with it. It is steroid sensitive. I'm going to let Jutley discuss that in Gurjeet discussed that in greater detail in a few minutes. I just want to mention that oftentimes this is a granulomatous iridocyclitis. It can be very profound. For example, in this patient here that we managed, this eye ended up being eviscerated. So it's a very difficult problem. It can lead to diseases and profound problems that are very difficult to manage. I do want to also mention that sector iris atrophy, like you see here, sector iris atrophy is not specific to HZ. You can certainly see it also in herpes simplex. In fact, more commonly in herpes simplex. I wanted to point out this whole issue of zoster without a rash. One of my co-fellows at the Proctor Foundation was Ivan Schwab, a brilliant ophthalmologist and professor of ophthalmology at UC Davis. Ivan published a very important paper in 1997 in ophthalmology on 15 patients who did not have rashes, who had granulomatous iridocyclitis, in which they did serologies confirming that 9 out of the 15, 2/3, had varicella zoster virus as the cause, or the likely cause, of their case of uveitis. So this is zoster sine herpetae, which can still manifest as an ocular problem without the cutaneous rash. I mentioned that unilateral sector iris atrophy is not specific necessarily to VZV, and in this important paper by Vanderlei, noticed that most cases of patients who present with iris atrophy, this moth-eaten type lesion, most of them actually had underlying HSV as opposed to VZV. That moth-eaten area, and I'm going to let Gurjeet discuss that in more greater detail. So let's move into management for a few minutes and then vaccines. So in terms of management, the first aid, if you will, the acute management, warm compresses, moist compresses. We have a product called Domboro or Domboro solution, which is an astringent, a 5% aluminum sulfate pomade, if you will, that one can put on these lesions. It doesn't really kill anything. It's not an antimicrobial, but it does dry out. It dries out the lesions. Betadine washes certainly to protect against any bacterial superinfection. Antibacterial ointments, again, are good, are appropriate. I would avoid neomycin in general because it's very sensitizing. Acyclovir ointment for these lesions, topical acyclovir ointment, is relatively ineffective in the immunocompetent group. It may have efficacy in the immunocompromised group as a topical medication on the skin. In terms of antivirals, as you know, IDU, Viroptic, Vidarabine are ineffective in vivo. Topical acyclovir and BBDU are effective, but we don't have them here. I'm curious to hear how you are using them in Europe. Again, cyclovir we do have. It is not on label for zoster, but it certainly has efficacy in vitro. Cycloplegics we would use in the cases of zoster that have a uveitis and where there's inflammation to cycloplege the eye. And of course, the whole notion of topical steroids in zoster, I would argue strongly that you would reserve them for those aspects of zoster that have an inflammatory underpinning. And Gurjeet will discuss that in a few minutes. Remember that if your patient is on topical steroids with zoster ophthalmicus and you see a worsening of the epithelial defect, that's telling you that there's a neuropathic, neurotrophic aspect to this condition, and you need to very quickly taper them. If you taper them overnight, you're going to have a huge rebound hyperemia and inflammation, so you need to rapidly taper them, perhaps not DC them overnight, discontinue them overnight, but rapidly taper the steroids. The whole notion of oral prednisone and zoster, an important discussion, and it still goes back to the two seminal papers in the mid-1990s looking at acyclovir with and without prednisone in patients with herpes zoster in general, not just ophthalmicus. So remember, these studies were done all comers with herpes zoster. There was no reduction in the severity of PHN whether you used oral steroids or not, but the important point is that there was an improvement in quality metrics. By quality, I mean quality of life metrics. Better sleep, less analgesic use, and return to normal activities were a bit better in the folks that had been given oral steroids in concert with or right after the initiation of oral antivirals, which we'll discuss, I hope, in the last few minutes of our presentation today. Oral steroids reduce the acute pain. There is no evidence that they reduce PHN. If you're going to use them 1 milligram per kilogram per day and taper them over a few weeks, a pearl that I learned from Dr. Deborah Langston, Debbie Pavin Langston, again at Harvard Medical School, Mass Eye and Ear Infirmary, that if you're going to use oral steroids in the management of herpes zoster, and I have rarely done this at all, I've rarely used oral steroids, but if you were going to, the recommendation by Dr. Langston is to use them, is to start the oral antivirals promptly the day you see the patient with zoster, ideally within the first 72 hours of the cutaneous eruption. Wait a few days before you add, if you're going to add, the oral steroids. Don't put them on at the same time. Can oral steroids cause zoster dissemination? Well, oral steroids would be contraindicated in a patient with HZ, or HZO in this case, who has diabetes or lymphoid malignancy or is immunosuppressed in any way, or in children. Remember that oral steroids are also beneficial for patients who are being treated with intravenous or intravitreal antivirals, who have, in the immunocompromised host usually, a retinal vasculitis and optic neuropathy in the concert of herpes zoster. So the various oral antivirals, of course, acyclovir, which is a guanosine analog, which inhibits DNA polymerase. Notice, by the way, this important last bullet point. The MIC 90s, the minimal inhibitory concentration 90s in vitro. For HSV1 is 0.125 micrograms. For HSV2, 0.25. It is 4 times higher to almost 80 times higher, if I've done my numbers correctly. 20 times higher. So it's 4 times higher to 20 times higher for VZV, which shows you how much more recalcitrant and resistant the varicella zoster virus is to oral antivirals, which is why we need more of them than when we're treating VZV, meaning zoster, than when we're treating simplex. So for acyclovir, if that's all you can get, it's 800 milligrams 5 times a day for 7 days. That's 4 grams a day for 7 days. It would be certainly ideally beginning within the first 3 days or first 72 hours of the rash, but if they come in on the 96th hour, give it to them anyway. The argument is to give it to them anyway. You want to get them on the antiviral within the first 72 hours. But even if you don't have the privilege of seeing them, they came out of the woodwork a few days after their rash, 4 or 5 days later, you've got to give it to them. Give it to them anyway. Give them the 7-day course. Challenge them with that 7-day course, in a sense, regardless of when they present. But ideally, you want to get this in. This is how the studies were done when we did the pivotal trial here in the United States. This is how they were done most effectively in the first 72 hours. Reduces viral shedding, shortens its duration, reduces the intensity of pain, does not reduce the incidence of PH, but it does reduce the incidence of herpes zoster keratitis and iritis. We prefer valacyclovir because its bioavailability is 3 times greater than that of acyclovir. Acyclovir by oral dose, 80% of it is excreted, only 20% is available. For valacyclovir, it's 3 times better, therefore you don't need quite as much. The recommendation here in the States is that we would give this 1,000 milligrams TID for 7 days, which is 3 grams a day, and that exceeds the MICs. Famciclovir, which is not the, I should mention that valacyclovir is the prodrug of acyclovir. It's the L-valo ester of acyclovir. So it goes in with the valo ester. The valo ester gets cleaved in the gut, and acyclovir is bioavailable in the bloodstream. Whereas famvir is a completely different medication. It's a deoxypenciclovir ester. It's the prodrug of penciclovir. It has very high bioavailability, almost 80%, so you don't need quite as much, between maybe 1.5 and 2 grams a day for 7 days. We don't have cerebudine here in the States. I will leave this to Gurjeet to discuss, and we don't have BBDU here either in the States, so I don't know how compelling it is and how useful it is and how common it is being used. We don't have cidofovir here labeled for oral use, but cidofovir is being used intravenously for patients who have acyclovir-resistant infection, meaning in the immunocompromised population, in folks that have zoster retinitis, certainly cidofovir is a choice. I mentioned earlier the issue of zoster and malignancy. This is a very complex discussion, and therefore I will just leave it to say that it can be associated with cancer. Patients with zoster were found to have a 9-fold risk of a subsequent cancer diagnosis. Patients with cancer have a 40% higher chance of getting herpes zoster ophthalmicus. Zoster and AIDS can cause a lot of problems that are more profound, deeper, and harder to manage than in patients who are immunocompetent. Here you want to certainly evaluate anybody who's under the age of 45 who has HZO to evaluate them for their immune status, because it could be a manifestation of immunocompromise. I mentioned the issue of PK or corneal transplantations in zoster. Those would only be considered in patients who have normal sensation, normal intraocular pressure, and controlled inflammation. I would recommend interrupted sutures and a lateral tarsorrhaphy for these cases. I've done several in my career. This patient on the left would be a candidate for PK, assuming IOP is normal, sensation is normal, and no inflammation. This is not a candidate for a PK. This is a neurotrophic keratopathy on the right, as we saw. These are the classic articles that have been published on PK and zoster. Notice that most of them had lateral, in the Reed series, most of them had tarsorrhaphy. In the Tanner series from the Wills Eye Hospital, not as many had tarsorrhaphy. This was my own experience in my career. 8 eyes with lipoidal scarring from zoster. Pre-op vision was all less than 2,200 in all these cases. They all had lateral tarsorrhaphies. 2 out of 3 had clear grafts at 2 months, 24 months. Do notice that although the visual acuity was better in a majority of them, there were consequences: hypotony in one of the patients, corneal haze, and chronic angle closure glaucoma. I mentioned the issue of neurotrophic disease, and in that case, you want to rapidly taper your steroids. If you're going to use contact lenses, very short-term use of lenses. Lenses are not appropriate in long-term management of anybody with a hypostatic cornea. They're just going to make things worse and breed bacterial superinfection. You could consider acrylics as a short-term strategy, but I would argue strongly for tarsorrhaphy, and if they refuse tarsorrhaphy, for conjunctival flaps. My experience with autologous membrane transplants is that they don't last long enough to solve the problem. These are chronic problems. You need conj flaps here, not AMT in this circumstance. And as I mentioned, PK is very poor prognosis in neurotrophic disease. This is a case that I saw, again, first year in practice. Patient comes in with her daughter saying that mom has a black spot on her eye, history of herpes zoster, neurotrophic keratopathy, corneal melt, uveal prolapse. I excised the prolapsed uvea, put a scleral patch graft in, and notice what I did here. I put a conjunctival flap over the scleral patch, because otherwise that sclera will melt down the road. So you want to, if you're going to do these types of patches in perforated cases, make sure that if you're going to use cornea or scleral grafting, make sure that you pull conjunctiva over that to prevent further melting. And finally, in the last few minutes, I want to mention the vaccines. I mentioned Varavax for chickenpox, Zostavax for zoster, and the newest medication we've had here in the States since October of 2017, the Shingrix vaccine. The Varavax vaccine was approved in the late 1995, so we've had it since 1996. It is now incorporated in the MMR vaccine here. The mumps, measles, rubella vaccine is now the MMRV. It certainly reduces the risk and incidence of chickenpox, varicella, reduces the severity of varicella, and of course it has changed the whole epidemiology of VZV, and it's not without its own morbidity. 3% of patients can get a zoster-like rash. It's a short-lived, well, I should say relatively short-lived CMI. The levels do hold for 10 years, meaning that a child who was immunized at age 2 may need a booster shot in their teenage years. That's still being worked on by the pediatric community, but certainly this is not lifelong CMI. The levels decline in a good portion of patients. The Zostavax vaccine, which is, again, it's the same live attenuated OCA strain of varicella, but just a lot more plaque-forming units, PFUs. The plaque-forming units in Varavax are dramatically higher, 19,400 per dose, than in Varavax. So it's a more powerful attenuated, meaning live but attenuated. They're not as strong, these viruses, to create a more robust, profound, cell-mediated, that is T-cell immunity. In the Oxman pivotal data that was published in the New England Journal in 2005, you can see that there's a 51% reduction in zoster and a 2/3 reduction of PHN versus placebo. Zostavax does not confer lifelong immunity. It reduces the morbidity, reduces the incidence of herpes zoster by about 70%, and it reduces the morbidity and has its own morbidity, excuse me, of about 2%. The ACIP committee here at the FDA allows the Zostavax vaccine to be given to any, allows it to be given to any immunocompetent host over the age of 50. That's an important age group to remember. Over 50, it's allowed to be given. Contraindications are folks that have immunocompromised status, leukemia, lymphoma, uncontrolled diabetes, who have an allergy to neomycin, who are pregnant, who have untreated tuberculosis. It's contraindicated in the AIDS population and those who are on steroids. It's not cheap, but it's usually covered by insurance. Can you receive Zostavax vaccine if you've already had shingles? Yes, but I would wait several months before vaccinating. Does it work in active zoster? No, there's no effect on existing zoster. In fact, it's not necessarily safe. Zostavax has been reported by several authors to actually be the reason for recurrent HZO, keratitis, or keratouveitis. So it actually may exacerbate existing disease. And finally, the Shingrix vaccine, which is the new zoster vaccine by GlaxoSmithKline. It's a recombinant subunit vaccine. It does not derive from either live or attenuated virus. It all works on that. Remember that first slide, that glycoprotein E on spike on the surface of the phospholipoprotein coat of the DNA virus of zoster, of varicella, and it has an adjuvant system to increase the power of the immune response. It increases CMI. It's much more powerful than Zostavax. It's a bit more cumbersome. You have to use it. You have to give it in 2 separate injections, sooner than 2 months apart, and as long as 6 months apart. So injection number 1 today, injection number 2 between 2 and 6 months from now. It's approved on anyone who's immunocompetent over the age of 50. 90% effective in preventing zoster and reducing PHN. At least 4-year data we now have that it's still effective 4 years out. It is now currently the most preferred vaccine here in the States over Zostavax. And you can give it to people who've had Zostavax. I would wait at least 6 months if they've had the Zostavax vaccine to give them the Shingrix vaccine. That's my talk. I'm sorry I went a few minutes over. And so I'm going to sit back and enjoy Gurjeet's talk. And then I guess we'll have a discussion after that. So thank you so much for listening. I hope that some of this material was of value to you. Thank you.
Yeah, Gurjeet, if you want to share your screen.
So can you hear me, Maria?
Yeah.
Perfect. So thank you very much, Vincent. I just also been adding participants in each whilst he was talking. And I saw in the audience that there's Tom Flynn and Charles Clowie. And if they want to participate in the discussion at the end, it would be a great honor to hear from them as well. So at the beginning, what we decided, we're just going to continue with the talks and then have a discussion at the end. So I've been passed the baton over and I'm going to run with it. And like Vincent, I prefer using case studies to highlight teaching. So I'm going to give my case study that was done quite recent, just to touch on the basic facts and pathology and look at the evidence both medically and surgically of managing these patients, and wrap up with a few take-home points. So my gentleman is ST, a 41-year-old Caucasian man who presented in casualty in November with a tentative diagnosis of right HSV keratitis and hypertensive uveitis. And quite rightly, he was treated with topical steroids, oral and topical glaucoma medications, and oral antivirals. A couple of days later, he presented for a corneal opinion where he was swabbed for HSV. They tapered the dex and stopped the Diamox. A couple of weeks later, things going well, presented to CAS, negative swab, no inflammation, further tapering of the dex, and they stopped the glaucoma medications. But unfortunately, within a month, things deteriorated. There was a fresh, described as a dendritic ulcer, and the pressure had gone up to 41. They re-swabbed him, and subsequently the PCR was positive for varicella zoster. The clinician who saw the patient wasn't quite sure whether it was a steroid response or whether there was inflammation in the trabecular meshwork preventing outflow of aqueous. So they continued on BD Maxidex. So as the clinical vignette progressed, there were sort of red flags, including the patient presented to casualty period of 9 times over 3 months, each time with fluctuating pressure and fluctuating amounts of inflammation. Now, he saw different clinicians on each visit, and quite rightly, they modified the treatment. They increased the DEX, they increased the glaucoma medications, but interestingly, also, they started and stopped oral antivirals, and on one occasion, they debrided the pseudodendrite. Now, this coincided all with the COVID period. So we were seeing high-risk patients. So he presented to our glaucoma clinic, and on 2 consecutive visits, he had visual fields, which showed a nasal step, which was non-progressive. And finally, I saw him, and we had a discussion of surgery, as without the Diamox, it was impossible almost to control his pressure. So I'm going to go through this in the midst of the talk. What were the red flags? Well, he's young. He presented with high pressure, and he had cyclical amounts of inflammation necessitating multiple visits to casualty. Question we're going to answer: should all drops and tablets have been started immediately? This domestos kind of approach. I'm also going to talk about timing of surgery, what should be the preparation before surgery, and ultimately, could we have avoided the visual field loss that we saw? I'd like to get Vincent's opinions later, the value of the swab, when should it be done, and his thoughts on the debridement of the pseudodendrite. So, anatomy and incidence. So if you think about it, herpes zoster affects 0.2% of the population. As we've heard, HZO occurs when the varicella zoster virus is reactivated in the ophthalmic division of the trigeminal nerve. Now, as ophthalmologists, we don't really care about V2, V3, but think about this. HZO, it represents 25% of all herpes zoster, which means that's a massive problem in our clinics. The literature shows that in patients with herpes zoster, the ocular involvement has been quoted as 20 to 90% of patients. And as we've heard, Hutchinson sign or involvement on the ali is strongly associated with keratitis, uveitis, and hypertensive uveitis. And this is the paper by Zeto et al. And they showed that the ocular involvement in their study was 65% of patients with HZO. And moreover, the cause of visual morbidity was keratitis, whereby once the initial HZO had resolved, 60% of patients had a reduction on VA of less than 612 because of keratitis. Now, if you grouped patients into HZO and herpes zoster, in the former, you were 13 more times likely to have uveitis, 13 more times likely. Oops. Now, it sounds quite intuitive that if you see uveitis, no matter the etiology, you want to start steroids, right? You see cells, treat them with steroids. Now, there's evidence behind that to say, yes, it's a good thing to do, and there's evidence against that. So if we look at an eminent paper in the mid-90s performed by Marsh et al. In Moorfields, they received treatment-naive patients and they randomized into topical acyclovir, topical steroids, and both. And what they showed was in the acyclovir group, there were treatment failures of up to 40%, i.e. 12 out of 30 patients. Once you stop the acyclovir, there was recurrence of ocular inflammation. When they looked at the concurrent use of acyclovir and steroids, there was some degree of benefit, but it wasn't statistically significant. Converse to this, if you look at an older paper, 40 odd years ago from Southampton, they looked at 40 patients with HZO. And what they showed in the topical acyclovir group, it was much quicker to resolution of symptoms. I think it was 75 days compared to 280 days in the steroid group. Moreover, once you stop treatment, there were no recurrences in the acyclovir group, but there was 65% chance in the steroid group that you had recurrence. So in this study, I think they used betnazole rather than dexamethasone, but you can see that whilst there is an intuition and consensus to use steroids, the evidence is not wholesale and it's quite conflicting. And I was speaking to Tom Buckley. Thank you, Tom, for your help in this talk. And he's told me that there's a registrar who's working with us at Amelia who's setting up a prospective RCT looking at topical acyclovir plus or minus steroids. And hopefully that will aid us with further information in the matter. Now, in the literature, generally, about 50% of patients present with elevated pressure in the hepatic uveitis kind of subset, and 2 to 40% convert to glaucoma. I've just presented here Hoeksema's paper, where they showed that up to 75% of patients with herpetic disease had high pressure, and 15% of these developed secondary glaucoma with a median time to developing glaucoma of 4 years. Out of these 73 patients, about 65% needed pressure reducing drops, and just under 20% needed a surgical intervention. Why I like this paper was that they started describing risk factors, i.e. the majority of patients that went on to have high pressure did so already at presentation, 91%. Moreover, an independent risk factor for developing glaucoma was the amount of time they presented with high pressure and inflammation. So if you look at my patient ST at the beginning, the red flags were there. He presented with high pressure and he presented multiple times, 9 times over 3 months in casualty. So why do we get high pressure in uveitis? So this is a question you're often asked while you're on call. And I often tell the person on the other side of the phone is don't go into autopilot. Our instinct is probably to start Diamox and do a PI, but the etiology is very critical. So think about very common causes, trabeculitis, i.e. you've got clogging and swelling of the trabecular meshwork. And the only way you can note that this is the etiology is if you give steroids, so tons and tons of steroids. And if this works rapidly to bring the pressure down, you know trabeculitis is the etiology. Choroidal inflammation causes rotation of the ciliary body and the anterior displacement of the lens iris diaphragm. And UBM can be quite useful in that situation. With respect to chronicity, you can get formation of 360 posterior synechia, i.e. pupil block or relative pupil block if you've got fibrin in the AC. You need to dust off your gonio lens, look at the angle because you'll see broad-based peripheral anterior synechia. Now imagine a situation where you've got 360 PS, you've got pupil block and you've got inflamed eye. What happens is you get ciliary body shutdown. I.e. you're getting low pressure because of the ciliary body shutdown. But if you give these patients that are inflamed lots of steroids, what happens? It kicks in. So aqueous is produced, but there's nowhere for it to go because of pupil block. So you get a situation of acute on chronic. So I'm just going to move on and run a video because what I liked about this happened 2 weeks ago when Yair and I were in theatre together. This patient was listed for a phaco-MIGS, but I want to show you what I found when I put the gonio lens on. So you often asked questions about what drops to give in a hypertensive crisis. I would say probably avoid pilocarpine because it exacerbates inflammation. Use prostaglandins last just in case it does exacerbate CMO. But the key thing is lots and lots of steroids. So then the second question for that is about the steroid response. Now, usually when you give topical medication, you will see a steroid response about 2 to 3 weeks post commencing the drops. And you can even see it months after giving intravitreals. But the key thing to remember, these patients do not have underlying glaucoma. They start off with good nerve function. So the long-term morbidity is not from a steroid response, it's from sort of unchecked inflammation. So giving the steroid definitely trumps the so-called steroid response. And that was me using the word trump in my American talk. So we're often asked by trainees the role of the PI, and you can see that in certain situations in the slide before that I've just presented, a PI would be useful, right? When you've got pupil block, i.e. 360 posterior synechia or acute on chronic. Now, many authorities will do a PI different ways. For example, you hear people say, I'll do a argon P treatment, give topical Dex pre-hand, maybe do multiple PIs. Personally, I don't do that. I think they all close up. So what I would prefer is a surgical iridectomy. And I think these patients do better with a surgical iridectomy if you are doing an iris procedure. I'm just going to run this video along just for the for time. I just want to get onto the angle bit. Okay. Right, great. So this patient was listed for a phacogoniotomy, and when I got there, I saw these broad-based pairs. So I just did a goniosynecholysis, which is a talk on its own, the merit of GSL, and whether we should be doing it after 6 months or so. Now, this is a $64 million question. We've already seen and heard that with topical acyclovir alone, you get recurrence rates of 40%. So as we've heard already from Vincent, that we would expect the oral to be better. Well, with acyclovir, we know there's poor systemic absorption, which limits the efficacy. So despite the fact that you'd think that topical would apparently work better because of better penetration, clinically, oral acyclovir is much more preferred, and it's better acting. The second point I wanted to raise is, when do we give it? Unlike HSV, VZV is replicating only at the beginning of disease. So it's very important that you give it quickly and you give it hard. So hit it hard, hit it strong, hit it early. And this paper is by Neo et al., which they looked at as an RCT of treatment-naive patients given topical acyclovir and oral acyclovir. I'm just concentrating on acyclovir because that's what we give quite a bit of in Oxford. Now, what they noted at all times of the follow-up period, the oral acyclovir group were less likely to have intraocular complications than those receiving topical ointment. And that was more statistically significant at month 3 and month 12. And if you look at the cumulative analysis, it showed that there was 68% chance of developing ocular complication in the topical groups, and it was half that in the oral group. Looking at risk of developing uveitis, in the topical group, there were 13 episodes compared to 6 in the oral group. Now, this is an important question because you often asked, and it's a difficult question to answer, how long should you give antivirals for, right? So I'm just presenting a study by Mizrachi et al., and they looked at 241 eyes with herpetic eye disease. And they gave, there was no details about steroid use, but they gave oral acyclovir and another group of no antivirals. And they noted that there were 2.1 recurrences of ocular inflammation on the oral group versus 3.4 without. The mean time of antiviral therapy in this study was 25 months. The most common side effects were GI disturbances and abnormal LFTs. So when you've got patients on oral antiviral medications, it's important to do regular LFTs and use an ease. Oops, apologies. So I'm just going to here present an important slide, which is a questionnaire published in Cornea last year. I found it quite interesting, particularly, it made me scratch my head to think, I wonder what non-specialist ophthalmologists are doing, because this is a study of 123 investigators who are actually participating in the Z study. The numbers presented in the pie charts are actual numbers, not percentages. So they were asked, in recent onset and chronic HZO, what's your management of choice? And 50 and 53% of people, respectively, used prolonged antiviral therapy for as long as they were using topical steroids, i.e. for more than 1 year. And majority were doing high dose at the beginning and tapering down after a couple of weeks to leave you on a sort of basal level. So in the same study, however, so converse to their 50% colleagues, if you looked at recent onset and chronic HZO, 11 and 12% respectively were not even using antivirals at all. So you can see that there's a huge variability in the use of antiviral medications. And that's why I think we're waiting for the results of the Z study with great optimism. The Z study, for those who don't know, it's 200 investigators over 60 different units in the States. It's an RCT answering one specific question: does prolonged suppressive oral valacyclovir treatment for 1 year reduce complications, specifically intraocular and incidence of post-herpetic neuralgia? So we've mentioned from the Hoek-Siemers paper that up to 20% of patients require surgery to reduce pressure. So that liberates many questions. What type of surgery, when to do surgery, and how is the preoperative status of the eye should be. So personally, I have quite a low threshold, and essentially my aim is to get patients to a reasonable level of pressure without Diamox. Now, to answer when, I suggest that there's an ideal situation and an ultimate situation. Ideally, the inflammation should be controlled as long as possible. And various authorities will quote 3 months, although personally I don't have a number because there's no real consensus in the literature, but it's generally agreed the longer the eye is white, the better the surgical outcome. But ultimately, you want to do it before developing glaucomatous optic neuropathy. My brother's a rheumatologist and in internal medicine, so personally he will always tell me give oral steroids, PO steroids preoperatively, and I do, but other authorities will give topical, subconj, intravitreals. Now, what's the surgery of choice? Essentially, do not do MIGS or laser trabeculoplasty in these patients, because this exacerbates inflammation and further causes a vicious cycle of posterior synechia. But it's very legitimate to consider the age-old question in ophthalmology, tube versus trab. Now, I've got colleagues who will say, do a trab. If it fails, I can move on to tube. But personally, I always do a primary tube, a 250 Baerveldt, and I'm going to give you rationale for that as well as evidence. So my rationale is, firstly, as I said before, these patients don't have glaucoma, so I'm only aiming for a normal range of pressure, which can happen qualitative. Now, these patients often also need phaco. And if you've done this beautiful bleb, you don't have to jeopardize it by doing a phaco, even though if you do it temporarily with 5FU and beautiful hands, it's still not something you want to jeopardize. Personally, when I do a trab, I get a lower pressure than a tube. So if you're doing a surgery that you aim for low pressure, or you're likely to achieve lower pressure, plus you've got a situation of an inflamed process which tends to ciliary body shutdown, you're probably likely to get hypotony, and that's quite hard to manage both medically and surgically. So if you can avoid it, all great. And remember, this disease is cyclical, so what you're going to get is episodes of inflammation likelihood in sort of zoster related herpetic uveitis. So in a situation where you've got subconj inflammation and fibrosis in a tube, it's not the end of the world. In a trab, it will cause failure. So that's why I would go for the rationale of a tube. I'm going to present a couple of papers to substantiate that. Ceballos et al. In Miami, they had 24 eyes, uveitic glaucoma, medically refractory, all had tubes. The starting mean IOP was 31 on 3 lots of drops, and a year later, it had dropped to a third. A mean pressure of 13 millimeters mercury, and at the last visit 58% required no drops at all. There were two failures that they described, both of them in young female aphakic patients. One had a kissing coriolis and macular ischemia, but they both used 350 Baerveldts, which has a big plate. Now I'm going to contradict myself because I'm presenting a paper here from Melbourne by Quan et al. A few years back, and they had 82 cases of uveitic glaucoma, 9% of which were herpetic disease related. The most common early complication in this series, in both category groups, was hypotony, which was found in about a third of patients. But what they showed in the paper, that the qualified success rate of trabs was not statistically significant from tube. And furthermore, in the trab group, there was less drops required at the end of the study. Also, primary tubes were just as successful as secondary tubes. So in isolation, if you look at this paper so far, it seems doing a trab is the right thing to do. However, the plot thickens, because this paper, what I liked about it, it helped address the question of active inflammation, i.e. dispel the myth that inflammation needs to be reduced preoperatively, because what they showed and what they argued is that it's actually the level of recurrence postoperatively of inflammation, which is much more important. So to try to dampen down the inflammation preoperatively, these patients either received oral prednisolone at mean dose of 32 milligrams or intravitreal triamcinolone, and there was a mean duration from injection to surgery of 17 months. And what they showed, that active uveitis at the time of surgery did not significantly increase the risk of failure for trabs. There was a trend in the tube group, but it wasn't statistically significant. But recurrence of uveitis was significantly associated with surgical failure in the trab group, not the tube group. So if you had a trab and there was no inflammation postoperatively, the failure rate was 20%. However, if you had at least one episode of inflammation postoperatively, it jumped up to 55%. In the tube group, if you had no inflammation postoperatively, the failure rate was 14%, and this went up to 36% if there was one episode of inflammation. So I'm just going to run this video on while I talk. So as a fan of the of tube surgery, I read with delight the conclusion from this paper, in which they showed there was no real significant factors to affect the outcome of tube surgery, particularly the uveitis at the time of study, which we've discussed, the age and gender of patient, the type of glaucoma drainage device used. So here, I personally only ever use 350 or 250 Behrvelds. And using the Uveitis, I use 250, because as I said, you're not aiming for super low pressures. The intraluminal stent type used, here I'm using a Supramid, but in the next video, I'll show you a Proline. The location of uveitis and tube-related complications. This is the most important part of the tube surgery, because if you create a very loose sclerostomy, you'll note that you'll get aqueous draining either side of the tube, and that hypotony is bloody hard to manage. Just going to run that on. Now, the limitation of that Melbourne study was it was retrospective, and the two surgical groups weren't exactly matched, i.e. the TRAB had more active inflammation at the time of surgery, and the tubes, they had secondary procedures performed only in that subset group, not the TRAB group. So the most common one is removal of the intraluminal suture. So usually at 6 to 8 weeks, you get a hypertensive response. And at that time, you take these patients into theatre and just take out this massive, massive suture that you've hidden down in the inferior fornix. In this patient, because of COVID period, we'd start her on prostaglandin, and we let her. That's why you get a conj injection. But and I did take some out on the slit lamp during COVID. But it's ideal to take it off in theatre, because you get them to look down and then you can see the tube. So when you're pulling out the suture, you know that the tube hasn't migrated. So just to summarize, we've heard that early oral acyclovir and topical steroids, that's the key. The long-term role of antivirals will be further substantiated by the Z study, but it looks like it should be done. Our red flags in our case was young patient, high pressure on presentation, and many bouts of inflammation. Those are red flags to get them seen quickly in a clinic. And if you can't medically control the pressure, just whack in a tube. Here are my references, and then we can start thinking about moving on to a discussion.
Yeah. I'm going to bring into the discussion Dr. Chloe, who very kindly, I know that he had a very tight schedule today, but he managed to be with us. And I also bring to the discussion to Tom Flynn. Okay?
Thank you.
Yeah, thanks to both of you. And the chat is now open, so that if you want to do some questions.
Can I mention, while we're waiting for questions to be asked, Maria and Gurjeet, I wanted to mention that the Z study is organized by Dr. Elizabeth Cohen at New York University Langone Medical Center in New York City. And in the clinical trial, they are going to enroll 780 patients. That's a lot of people, almost 800. They have enrolled over 500 as of the end of May, early June. I don't have the exact data for this today at the end of June, but we're over 2/3 of the patients have been enrolled. And I want to point out that what they're using in the Z study is valacyclovir. Hi, Tom. Is valacyclovir 500 milligrams BID. Okay. Remember what I mentioned at the beginning of the talk, or the middle of the talk, when I discussed valacyclovir as a management strategy, which I recommend much greater over acyclovir because of bioavailability, that to manage acute zoster, we're using 1,000 milligrams TID, 3 grams a day for 7 days. The suppressive dose that is being used in the ZEDS study is 1 gram a day, 500 milligrams BID of valacyclovir. Remember that valacyclovir's bioavailability, it's 60% through the oral dose, as opposed to acyclovir at 20%. So that's a crucial distinction. And also, historically, for 30 years, I have used, episodically used, oral antivirals for a long time, for greater than 6 months, on patients who have an underlying history of HSV for corneal transplant. So if a patient has had a corneal transplant because of herpes simplex virus scarring and has had recurrent graft failures or inflammation or recurrent simplex in the graft, which is not uncommon, we use suppressive doses of valacyclovir empirically, at least at 500 milligrams orally once a day. We recommend getting BUN and creatinine clearance. We recommend, if you're going to be doing this for medical legal reasons, to perhaps have nephrology get involved, because even though the short-term risks of our antivirals are low, there are nephrotoxic and ototoxic consequences of long-term use of oral antivirals. You want to check kidney status. Doesn't mean you can't use them, but you may have to modify the amount that you use. But I'm digressing from the ZEDS study. The ZEDS study is 500 PO BID valacyclovir as a suppressive oral antiviral for 12 months. And then they're going to look out to 18 months to see what the frequency is of recurrence of herpes zoster keratitis or keratouveitis, just to let you know a bit more of the detailed granularity of the ZEDS study.
Yeah, to interrupt you, Dr. Chloe is with us. The video is not working, but he also would like to comment on something. Yeah. Charles, can you hear us? What? He says what?
Maria, whilst you're getting Charles up, I just got a question for Tom and Vincent. So in the UK, we have Zostavax available for those above the age of 70, but the caveat is obviously younger patients have a greater amount of ocular manifestations and risk of strokes. So do you think the vaccine should be targeted for younger populations?
Tom, you want to take that first?
Well, I was actually going to ask you, Vincent, because I learned a lot about these vaccines from what you spoke about just now. And it seems to me that, you know, rather than dealing with the issue of when to give the vaccine after someone has developed the problem, it's much better that they would have it, you know, before developing the problem. And I think I wanted to ask Vincent, do you find yourself, you know, being a kind of an advocate almost for vaccination in your patients or in patients of that age group? Or is it something that we need to be doing as a group, as a profession?
So, yeah, that's a great question. I don't know how much you all know about the FDA approval process, but when the FDA approved Zostavax, which I believe was in the fall of 2005, the approval was for 60 years of age and over. Now, the ACIP, which is the Committee on Infectious Disease Protocol within the CDC, lowered that 60 age group, all in immunocompetent hosts now, we're talking about immunocompetent hosts, to 50. So now the standard of care is anybody over the age of 50 can get Zostavax. And Shingrix, when Shingrix was approved in October of 2017, 2.5 years ago, it is labeled, FDA labeled, which gives us some sense of security at 50, again, 50 years of age and over. So the trend here in the States is 50 and over, get a vaccine. Ideally, the Shingrix vaccine, it's not as well covered by insurance as the Zostavax, which has been around 12 years longer. But it costs about $300, 2 injections, as I mentioned, for Shingrix, 1 injection for Zostavax. Zostavax is covered by most insurances, Medicare and privates here. I wanted to also mention that when you stratify the decades and look at Zoster over decades, interestingly, the frequency is highest between 50 and 59, not between 90 and 99. Or 70 and 79, but there's a bit of a blip up in that Gaussian distribution, and it isn't really Gaussian, it's sort of Kiefertic. But regardless, there is a blip up in the decile in the decade of 50 to 59. I don't know whether that was the reason why the FDA or the CDC lowered the allowable age at which to get these vaccines from 60 to 50. But as Tom implied, and as I implied in this talk, this is a devastating disease wherever it occurs in the body, certainly if it occurs in the first division of the trigeminal. And to give the vaccine earlier in life in an immunocompetent population seems to be relatively safe. There is morbidity. Don't forget, the Shingrix vaccine is not giving live virus. It's giving it's giving the glycoprotein E surface protein with an adjuvant. So it's not giving live attenuated virus, which is how Zostavax is made. So the risk of getting Zoster, you can't get it from the Shingrix vaccine as Zoster. You can get inflammatory responses. So that long digressive answer is to say, yes, Tom and Gurjeet, earlier better, 50 and over, yes, I would get it. I got the Zostavax vaccine a few months before Shingrix was approved, but I certainly could get the Shingrix vaccine now. As I mentioned in my talk, even if you've had Zostavax, if you could 6 months later or beyond, you can consider getting Shingrix. Shingrix gives you a much more profound cell-mediated immunity response, more CD4 T cells, arguably a longer period of time in your life during which the CMI is high enough above threshold to suppress recurrence of the varicella zoster virus. Whether children or teenagers should get Shingrix is another kettle of fish that I can't answer because it wasn't studied. But since we're giving everybody here in the States who has insurance and gets to see their pediatrician, since we're giving them Varivax as children, we've modified the epidemiology and the immunobiology of zoster because we're giving Varivax, which is attenuated Oca strain, live attenuated varicella zoster, to the pediatric population. So we're giving a viral vaccine against the shingles virus to children. We're not giving them Shingrix, nor are we giving them the higher PFUs per dose that we have in Zostavax, but we're giving them something. Remember, it's the length of time during which our CMI is good that's crucial. And as we get older, regardless of stress, trauma, fever, immunocompromised, surgery, CMI diminishes. Whether it's linear or logarithmic, it diminishes. And at a certain point, it's below where the VZV virus comes back out. And therefore, how long do these vaccines provide durable immunity? With Zostavax, it may be a decade. With Shingrix, we don't have a decade of data. We have 4.5 to 5 years of durability, because we're looking at the study, not just the approval date, but the couple of years before the approval date during the study.
Guys, Maria, is there any other questions from the audience? Otherwise, I've got a question.
I think Dr. Chloe, Charles, wanted to make a comment. Yeah, and then we've got Ahmed Chalabi as well. Yeah, to make a comment to us. Yeah. Well, I think Charles is what Charles wanted to say is that because I see that Charles, can you hear us and comment? No, okay, I think he cannot. So, but he wanted to make the point that it is important to treat not only to treat also skin rashes, the skin rash and the pain. Do you usually refer those patients, for example, to a neurologist for them to manage the pain, or do you usually manage yourselves with like a basic treatments, or like some that are easier to follow up, and then if not, you transfer the patient to a neurologist, for example? Or
my experience is I would consider giving Elavil, which is amitriptyline, 50 to 75 milligrams at night. And amitriptyline works not only as a neuroleptic of sorts, it has an antidepressive aspect to its work, and it has sort of an analgesic effect. So low dose amitriptyline or Elavil here in the States is something that ophthalmologists can, in a sense, safely give or relatively safely give. Lidocaine patches have efficacy, 5% lidocaine patches. I have found Zostrix, which is capsaicin, a substance P inhibitor, capsaicin, to be effective in about 1 out of 4, 1 out of 5 cases, so it doesn't really work. Anything beyond that, I strongly recommend that the patient sees pain management. And not even neurology, because neurology is now subspecialized, and it's the pain management subspecialists that have fellowships now in this aspect of neurology that are really best equipped to do stellate ganglion blocks. They're very, very keen on stellate ganglion blocks in profound PHN from HZO. And so I recommend strongly working with pain management neurologists. If you've gone beyond simple strategies like Elavil, you could consider gabapentin, which is Lyrica. You could consider that kind of a strategy as well before you move on to neurology. But I think that managing PHN is beyond the ken of most ophthalmologists. Unless you're a neuro-ophthalmologist and have an interest and perhaps fellowship training in this, I recommend strongly that these patients be managed quickly by pain management specialists.
Can I just make a point to the panel? Basically, Vincent, you said that you haven't used oral steroids much yourself. So just from my knowledge, I think there's no definitive study showing long-term incidences of PHN or ocular complications from steroids. You presented a paper from the New England Journal of Medicine '94. It basically, there was no long-term differences in terms of outcome. It was just shorter duration of symptoms being resolved at day 14, and the qualities were much more improved from what you said. So my question to you, everyone, is, do you use oral steroids? I mean, you said not. And if you do, would you do any serological tests before commencing?
Maybe Tom and Charles could answer that, because I don't use, my experience in my 30-year career has been not to use oral prednisone. I mentioned how to use it in those people that you want to try it on, which is a few days after you begin the powerful antiviral strategy. And again, here in the States, preferred valacyclovir over acyclovir if insurance covers it. Valacyclovir is generic now. That doesn't necessarily mean it's cheaper, but it's a generic now. Famciclovir would be the other choice, much better bioavailability. If you're thinking about using oral prednisone along the way, the recommendation, and this is from Deborah Pavin-Langston at Harvard Medical School, Mass Pioneer, is not to put him on both the acyclovir or valacyclovir or famvir and oral prednisone on day one, but purposely to immediately start them on one of those 3 antivirals, wait a few days for the viral load to diminish dramatically, and then add the steroids.
Why haven't you used it? Why haven't you used it?
I haven't used it because I'm not convinced that it makes any difference. I did present the fact that the quality metrics might be better in the people that were given oral steroids in both the Wood study in '95 and the Whitley study in '96, which were both published in the New England Journal. And those remain the seminal papers on whether or not, what the value is of oral prednisone in the context of managing patients with or without. Remember, they used acyclovir in those studies, not valacyclovir, not famciclovir. So there's an issue of bioavailability of the antiviral. That's another whole kettle of fish. I haven't used oral prednisone in my career because those two studies were just not dramatic enough for me to consider it. However, given that if indeed the quality metrics are better in patients, if it's giving them a bit better lifestyle, then consider it. But be careful, because you don't know everything about these patients. If they have an underlying immunocompromised status that you're not aware of, if they have an underlying leukemia or lymphoma that you're not aware of, then are you making them worse by giving them a profound amount of prednisone for their zoster, which then would then create a systemic increase in the manifestation of their underlying lymphoproliferative disease. That's one reason to avoid oral prednisone. Going to your question of whether these patients should be worked up. Well, how quickly can you work somebody up? You see them today, Monday. Are you going to be able to get all your serologies and a bone marrow biopsy CBC differential, platelet count, and everything in 24 hours, so that you can ensure yourself that this patient does not have, and I'm specifically discussing lymphoproliferative disorders because those are the ones that are most likely to be related to consequences with zoster, not small bowel or large bowel cancers necessarily, different immunology there. So the point being, how much can we know about our patient? If a patient comes in already with a history of diabetes, lymphoproliferative disease, other issues that render them immunocompromised, categorically do not use oral prednisone. In an immunocompetent host that is older and you're worried about bad PHN, because PHN is more common as you get older if you get zoster, there might be a reason to use oral prednisone. I'm not disputing that at all. I'm just telling you how it should be used if you're going to use it. And I would defer to those in the audience and panel who have experience using oral prednisone in the acute management of herpes zoster. And remember, zoster acute, we have to remember one thing that I didn't discuss because I did not discuss the neurology of this disease purposely for time. There is ZAP, zoster acute pain, which by definition is any pain in the first 28 days, the first month after the cutaneous eruption. PHN is defined as pain that persists beyond 4 weeks, beyond 28 days, or commences after 28 days. That's PHN. There's two different types of pain, ZAP and PHN. They're different, the neuropathology of these problems is different. So ZAP is a different kettle of fish than PHN. So we're really talking here about the acute use of oral prednisone in the acute cutaneous manifestation of herpes zoster, or the acute manifestation of zoster. And because I don't have a lot of experience, I defer to those that do. But I'm just giving you my strategies for how to use it if you're going to use it.
I agree, yeah, Vincent. I think it's wise to definitely defer steroid use until you have had the antivirals on board for a few days. And like yourself, I haven't really used oral prednisolone for the cutaneous manifestations. I mean, obviously, rarely you'll get patients with manifestations deeper, like scleritis, you know, causing serous detachment. I remember using oral prednisolone for a patient who had that problem in conjunction with a uveitis colleague. But most of the anterior inflammatory problems can be treated perfectly well with intensive topical prednisolone or dexamethasone, and they respond well. So it's not really necessary.
Tom, how long would you use antivirals for?
This is the big question, and I'm really looking forward to the results of the Z study, because, you know, I tend to use them short term, to be honest, like for 2 weeks. And then occasionally you'll have patients who do have some recurrences but can be controlled just with low dose topical steroid. I tend to do that, and I sometimes go back to revisiting the systemic antiviral if it's becoming a very frequent problem, if you're requiring a lot of steroid to get it under control, if they're getting into glaucoma problems, which of course they do. And another key message is make sure as a corneal specialist you have a good glaucoma colleague for managing these cases, because it's such a common problem. But I'm really looking forward to the results of the Z study, because I just don't know the answer to that really.
Maria, do we have any other questions from
Then
people?
the question becomes how I want to mention one quick thing, which is that we have patients who have herpes simplex virus keratitis, who have surgery, who've had grafts, who are on valacyclovir or acyclovir, perhaps sometimes famciclovir, certainly acyclovir or valacyclovir, for longer than 1 year. 500 milligrams once a day, I don't want to say indefinitely, but for years, with categorical testing of BUN creatinine and creatinine clearance. So renal function is being tested over time. Patients see nephrology along the way. But patients have been kept long-term, meaning beyond 12 months, on low dose, relative low dose, 500 milligrams a day, suppressive doses, what we consider to be suppressive for HSV. Remember the MIC differences between HSV and BZV. I showed those differences are dramatically different. The MICs for HSV are dramatically lower than they are for BZV. That said, we have many patients here in the States who are on longer than 1 year's worth of an antiviral to protect their transplant from rejecting. I also want to mention that paradoxically, what we might consider to be homeopathic doses of steroids, 1 drop a week of prednisolone acetate, that if you stop those, this is in the keratouveitis population, we've noticed over the decades as experiential heuristic things, if you stop that, what you would perceive to be a homeopathic amount of steroid, they flare. And then you have to then hit them hard, if you will, metaphorically, with Predforte or Durezol frequently during the day and taper them again down. And we have many patients who have keratouveitis by history who are maintained inflammation-free, meaning trace cell to no cells, trace flare to no flare. It's almost impossible to get rid of it, as you know, 0, 0, with what we would consider to be relatively homeopathic, if you will, doses of steroids. So that's another aspect of zoster, which is very curiously singular for this disease.
Maria, any other questions from the audience?
Yeah, I've just seen one from Ahmed Shalabi, a colleague from Oxford, and he says he would like to ask Mr. Jutley if in a combined phaco-syneculisis procedure, at what stage do you do the syneculisis step after the IOL implantation?
Yeah, I mean, essentially, once the IOL is in, if we're going to do a goniotomy or an angle procedure, you'd give myocol. So once that's in, we would then put in, ideally, if you've got heavy liquid, heavy helon, into the chamber space, tilt the patient, tilt the microscope, then put the gonio lens on. And the surprise here was that it wasn't picked up in clinic, which is not the end of the world, because once you put the gonio lens on in theatre, we just abandoned the goniotomy, and rather than doing that, we did the GSL. There was a paper last year suggesting that any acute angle closure with synechiae after 6 months, is there a point in doing GSL? Because bearing in mind, you can get a lot of inflammation, not to mention a degree of hyphema. But generally in this situation, I saw it, so I just pulled the iris away. We could have done the goniotomy at the end, because we did see the heme from the canal of Schlem, but for that patient, I didn't.
Okay. Yeah, that's from...
Guys, thank you very much, Maria. Thanks for that question. Any others?
Any other comments that you would like to make, or Tom, or?
I think, first of all, thank you very much, Maria, Tom, and Vincent, for an amazing session. I really appreciate that. And it was great to get Tom on board, who was a mentor of mine in London. And Vincent, it was amazing, really educational talk. And Maria, thank you very much for modulating as you have. So
thank you so much.
Thank you.
Thank you all.
Real good fun.
Stay safe, stay well. Thank you very much for this opportunity. It was a privilege and an honor to participate. Thank you. Great to see you.